Our session of this day, the co-chair is Professor Xavier of World Federation. Our first speaker will be Professor Jeremy Vincent, a well-known figure in critical care medicine. And he's the past president of the World Federation Society of Critical Care and the European Society of Critical Care, and author of an editor-in-chief or editor of several journals. And his talk will be about the role of AI will replace the intensive care team. Welcome.
Thank you very, very much indeed. And thank you for giving me a topic which I like very much. I like to speak about the future. And in just a second we will see my first slide, which will say, hello! So once again, it's a pleasure to be here at this excellent meeting. I've enjoyed the scientific program as well as the general atmosphere. And indeed, you asked me the question now, will artificial intelligence replace... Oh, thank you, I'm fine. Will artificial intelligence replace the ICU team? And the answer is obviously yes. Of course. Of course. Now, maybe not entirely. Before I discuss it, I'd like to say that I have no conflict of interest, except that I'm very enthusiastic about the development of artificial intelligence in medicine in general, and in critical care medicine in particular. And for those who read French, I was invited to write a little book by the Academy of Medicine of Belgium on our future. When we speak about artificial intelligence and what we fear, indeed, it is job losses that may come in front, loss of human control, and errors. And actually, to reassure people, it's sometimes better to replace the word artificial by augmented. Speaking about augmented intelligence, it's still AI, of course. And when I asked ChatGPT what's the future of artificial intelligence, actually the message has not changed very much over the years now. And yesterday, that's the list that ChatGPT gave me. And when you read the list, you can see early diagnosis, monitoring, ventilator management, treatment optimization, imaging, workflow. How can you imagine that this will not reduce the need for ICU personnel? Of course, we will need less ICU personnel. But since in many places we lack ICU personnel today, especially nurses, after the COVID crisis, well, you know, some of this may be tolerable, of course. And very importantly, it's a slow process. When I speak about it to the public, very often people feel that it's like a switch, no artificial intelligence, artificial intelligence. I'm telling them it's a slow development, like internet, like the cars that we see today have nothing to do with what we did see in the past. So when we speak about AI, it could be at the bottom, the very narrow spectrum. We all use AI every day when we send a text message, when the system tries to complete the words before we write them completely. When we drive our cars, there is some AI systems in it now. So I'm not saying that AI will replace humans totally. We need to find a reasonable way to go up on this list. This is my AI figure, helped by Alan, on AI in the ICU, and I will review some of these items, like assistance in procedure. So, were making progress even before the development of true artificial intelligence. When I was young, the nurse was coming regularly to the floor or to the emergency room to change the amount of oxygen that the patient would receive to keep saturation within a given range. But now, of course, this can be done automatically. Well, this is just a closed-loop system. Well, yeah, but it starts to be more and more intelligent. Now, if we move in the future, even endotracheal intubation can be done by a robot. And that implies, of course, some artificial intelligence. But if this can be applied in uncomplicated procedures, it will reduce the work that we need to accomplish. So as we know, robots will be everywhere. Tomorrow, I'll speak about anesthesia. And I'll speak about the administration of fluids on an automated basis and vasoactivation. Oh! Can you hear me now? Oh, very good. Thank you very much. That's okay. That's okay. Thank you. Thank you. Thank you. That we will actually learn from anesthesia, as already in 2019, it was proposed that robots will perform anesthesia in the future. But for CPR, we know now that the defibrillator could come with a drone, and so help to resuscitate in the wilderness. Okay? But soon, we will have complete CPR robots that will do the cardiac massage, that will ensure some gas exchange, and if someone can insert an IV line, we will use drugs. Of course, under the control of someone who could use telemedicine far away and guide the non-professional on site. Robots will decrease the need for physiotherapists, as they will help to stimulate the patient. I am Shora, I am your physiotherapist today, and I am a robot. A social robot will also accompany the patient, and simulation will learn a lot, will evolve a lot, so that we will accomplish our tasks better and faster. So all of this will reduce our need for interventions, even for logistic support. We know that robots can do a lot of things, even in restaurants today. Or here I took it in New Caledonia when I was visiting professor just before COVID. They already had these systems to bring material to the floor. So, with my good friends, Arthur Slutsky and the late Luciano Gattinoni, we wrote this piece some time ago on the ICU in 2015. And we wrote, actually, there are few doctors here all together. You never know when they really are, where they really are, when they appear on the screen. So it's not that doctors on site will be replaced by those in the distance, but that will come in addition to our work at the bedside. And so this brings the important question of how telemedicine will affect our work in the future. I wrote this with my friend Osterman, and we said, you know, with current approach, we would tend to centralize patients who need special techniques, like ECMO, for instance, special teams, sophisticated environment. There are some advantages, but there are also some problems. In the future, thanks to telemedicine with AI, we will sometimes be able to keep the patients here, but have the guidance from the big professor in the big center who could help us. We won't be alone. We will be here, but really in contact with those more experienced course, AI will help in diagnosis. It's quite easy. What we do is a rational process, collecting the information, making a differential diagnosis, and from there we will implement the treatment. This is a paper that just came out showing that ChatGPT is already quite good. And there are many papers. I have no time to speak extensively about this, but in an emergency department already, that can be very helpful to assess the patient in the front line. We know how recognition of abnormalities can be done automatically with an AI system. Is it better than humans? Well, yeah, this is now a classical paper showing that a lung cancer can be identified by AI before you can see it with the human eye. Going back to the CT scan 2 years before, you could hardly see anything wrong, but the AI system would actually recognize the very early cancer. How many animals with 3 legs? Quickly, quickly. How many? How many? How many? Oh, you are so slow. Of course it's 5. But the AI system will say, have you noticed that one animal has no tail? Oh, you asked me to look at the legs. Ah, okay. But I noticed tail is missing. And this is a classical study in the field of AI, where the system looking at chest x-rays at some point said, you know, you can identify the risk of diabetes from the chest x-ray. From the chest x-ray? Diabetes? No radiologist has ever said that. Well, look, by looking at the fat material around the lungs and the heart, the system can say, maybe there is diabetes. So, we must be careful, of course. We shouldn't go too fast. We agree. This is an animal. Which animal? Okay, there are some risks. And remember this very sad story. Facebook apologizes after its AI labels black men as primates. So, we have concerns about minorities, about the number of elements. When I was a young doctor, we started to have automated analysis of EKGs. And so doctors needed less specialists to interpret the EKG. But I was pleased last month to see a cardiologist saying, yeah, EKG shows this and that. I'll see what the AI system says. And the cardiologist, who is actually the head of the department of cardiology in our hospital, was looking at the current protocol, because sometimes you can see mild hypercalcemia that you did not suspect. This can indeed be recognized by AI. We all know how radiology will change. Now the x-rays are automatically interpreted. And people may say, you know, the doctor is still better than the AI system. Well, maybe. But let's look at it with this scheme. The doctor will get better over time, maybe much better upper line, or somewhat better the lower line. But in any case, at some point, the doctor will get somewhat older, and the doctor will retire, and the doctor will die. Well, another one will come, and maybe could be somewhat better. I agree. Okay. And then another one. Okay. But the AI system will stay there, perhaps forever. So the AI system learns and learns and learns. So it's impossible that it does not become better than the specialists. I don't know if it will be a straight line or not. It doesn't matter. The AI system will become better. I showed this slide about 10 years ago. And I said, look, And yeah, it was Trump there at the left-hand side, but 10 years ago. And the system says 360 million of images in 24 hours. Wow! And this was exciting the audience. Today, people laugh at them. In 24 hours, in 24 minutes, or less than 24 minutes, of course. So, you know, there is another concept which is very important. It is a concept of collaboration. Is it important to identify RDS on the chest X-ray? I don't think so, but that's another topic. I'm not sure we need to identify RDS because it doesn't change patient management. Necessary. So, is this X-ray compatible with RDS? Sometimes we have some disagreements. Yeah, maybe no. Okay, look at this study, where they showed that when the physician was certain that this is indeed ARDS, okay, it was labeled as ARDS. Likewise, if the AI system was certain and the physician not so certain, okay, it was considered as ARDS. But I like the bottom part of it, when actually the two can communicate. And it's by combining the two opinions of the AI and the doctor that we can actually pose a diagnosis. I like it because it's really collaboration. It's not the AI system which will decide necessarily, but we have a pilot and a co-pilot. And the monitoring systems will change dramatically. I'll speak more about it tomorrow again, but we will have automated echocardiography. And right now already in our department, we could have, unfortunately the company went bankrupted, but we could have the image of the heart contracting on the screen in the room. Another company will come and this will be applied even non-invasively, of course. And the analysis will be automated. The VTI, the velocity time integral reflecting stroke volume, will be obtained automatically. And actually, did you see this paper? We can have automated acquisition and analysis. Maybe in the future we will no longer need all these echocardiography courses because the machine will do it for us. Do we need to be experts in ECG, in EKG, if the machine can do proper analysis? And this will reduce the need for doctors. For nurses too, we won't have to bring the patient to the CT scan. Okay, we are going to the radiology suite. No, no, the CT scanner is at the bedside. Even MRI. Now it's available for the head, but the industry tells us that they will be able to go down and have images of the thorax to adjust PEEP, for instance. So that will reduce in less needs for personnel. And then, of course, treatment. Integrating multiple variables is a great advantage of AI systems. We always speak about the radiologists that will no longer be necessary. But what about the infectious disease specialists? What do? Well, they take all these elements into account, source of infection, microbiological data, ecology, etc. And from there, they propose a treatment. But that can be done by AI. Undoubtedly, and this has been described already 20 years ago by the Salt Lake City group in the US. We spoke briefly about managing ARDS yesterday. What about the optimal PEEP level? Well, it's not just the PEEP level, it's the plateau pressure, it's the driving pressure. Combination of these variables is complex for our brain. The human brain can combine one or two or three variables maximum. But here we can combine as many as we need to.
And we can integrate EIT, we can integrate the hemodynamic data. When we increase the PEEP, there may be an effect on the right ventricle and the heart. Assistance in monitoring, I will shift because the time is running. I will end up with the assistance in prediction. From a number of data which are properly integrated, we can much more predict what will happen. Right now, many people don't use it so well because predicting a fatal outcome is not so interesting. We already can do it when we look at the patient, as I mentioned yesterday. Predicting renal failure, if there is no specific treatment. Oh, avoid nephrotoxic agents. I always try to avoid nephrotoxic agents. Oh, give enough fluids. I always give enough fluids, etc. So prediction, we need to emphasize this, is only important when it can lead to prevention, when we can do something about it. We all speak about early recognition of sepsis, but that's true for many potential complications. If we can identify it early enough, the field of sepsis, we could use X-rays, we can take more bacteriological samples, we can reevaluate the situation before it is septic shock. And of course, intelligent alarms will change our world. We will look at trend analysis, and so that the alarm will go off, not necessarily when we go off the usual range, but when there is a change from the usual, from the baseline values. And again, integration of signals that may result in an early alarm, no longer in a big center in the hospital, but directly on the pager of a doctor who can go to the floor, bring the patient sooner to the ICU, and this will result in actually less activity in the ICU because we bring patients before they are almost dead, right? So that will be indeed a very important development. So, finally, in closing, the evolving role of nurses and doctors. Nurses will see their work changing, of course. They will use more telemedicine, of course. They will rush less from one patient to the other. There is a risk that we will look at the computers more than at the patients. We must be careful about it. Clearly, we still need to be at the bedside. But the doctors and the nurses will have more time to discuss with patients when they are conscious and families. And this is essential. People complain about the fact that we do not take enough time for planning, for discussion. So we have made progress and we will continue to make progress, and we need to embrace these developments, being happy to see that we will be more efficacious, and this will be for a better quality of care. We will need less personnel, but still keep humane care or even increase it. And I fully agree with Topol when he says that the future will not prevent us from being humane, present, and taking care of our patients in a very appropriate way. Thank you very much.
Thank you very much. Thank you, Professor Vincent. We are changing completely the topic for the next speaker. We'll leave the questions for the end of the session. Dr. Wesley Eli is a well-renowned expert on cognitive dysfunction, coming from Vanderbilt University. Is going to speak about humanizing the ICU. So it's a completely different topic. We went from computers and artificial intelligence to human ICU. So please.
Wow, Jean-Louis, I don't need Hollywood anymore. You're the most entertaining speaker. I could listen to you. No, I could listen to you all day. It was amazing. That was fantastic. Thank you. And actually, as I was sitting there listening to you, I was thinking, this is a perfect segue for the talk. And I really think these two talks go together so beautifully. And I loved it in your talk. I don't think this is on yet, by the way. Oh, I don't.
Now it's on. Ooh. I loved it in the talk when you said we're a pilot and a co-pilot. You guys need to turn it down a little bit. That pilot co-pilot thing, that's perfect, because clearly we have to employ AI, and we won't even have a choice to do it. It's going to be there for us. But I love the idea. What I worried about originally was we would be replaced. But you made the point that we won't be replaced. It'll be a commensal relationship with the doctor being the pilot and the AI being the co-pilot. And I love that, that image. Let me get my tools. Thank you. You can pull the slides up whenever you're ready. You want to open up the slides? Okay. So I'm going to talk about the intersection between science and humanism. And we love our science. We absolutely love our science. We love our papers in critical care and in ICM, but we also love our papers in Lancet, New England Journal, and JAMA, the top 3 most powerful, high-impact journals on the land. And what I'm going to do is I'm going to take you through a combination of human story and science that has been published in the New England Journal, JAMA, and Lancet to bring forth this idea that science will never be enough for the patient. Because the patient needs us hand-holding, kneeling with them, looking in their eyes. And we have to balance these two things between the science that I and you love and the AI, which was just beautifully elucidated by Dr. Jean-Louis, and then also this touch of the bedside. I can do this talk without slides, but if you guys get them up and going, let me know. So it's been said that love's second name is mercy. And I'm going to talk, essentially what I'm talking to you about is mercy today. Well, by the way, we're starting at 8:40, so I'm going to do my best to get through on time, but we're probably just going to use up all of our Q&A in this circumstance. If love's second name is mercy, I think that mercy is present in this modern day world in the form of our caring for another human being who's in front of us. And AI can never do that, and science can't provide that either. So we have to figure out a way to combine this notion of human touch and eye contact and then the delivery of critical care. I'm not supposed to be doing anything with this computer, right? Y'all are trying to get it up on the screen? Okay. So I have no disclosures, no financial disclosures with any industry relationships, and I do have permission to tell you any of the stories I'm going to tell you today. And at the end, we're going to come back to mercy at the end because Dr. Arabi is going to read us in Arabic out of respect for the country that we're in and the culture that we're here. We're going to have a little bit of a short excerpt about mercy. I am part of a research group at Vanderbilt University, which has about 120 people in it. We have NIH and VA funding, which is part of my disclosure. And I am conducting with these people lots of different investigations that intersect this idea of humanism and science. When I first got started in critical care, the patient that I first cared for at the bedside was named Teresa Martin. Teresa was a young woman in her mid-20s who had a son named Travis. And when I cared for Teresa, I put all the technology I could into her care. I blew up her lungs because we weren't using low tidal volume. She had 8 chest tubes. I said callous things about her like she's a V8. I thought that I was being a good doctor for her. And despite all of my iatrogenic errors, she lived. And this was in 1990. And I asked her to come back to clinic to see me. And when she did, it was my first post-ICU clinic. I'd never seen a patient months after critical care. Teresa was wheeled into the room in a wheelchair, 25 years old. Hey guys, let's just forget the slides. I'll just do it without. I think it's somewhat distracting. I'll just do it without slides. How about that? It's fine. When she came in that day, she couldn't walk. She couldn't go back to work. She couldn't talk to her son and raise him. And once I saw that, I had no idea why she was so broken. I thought we did critical care. She had lung failure. We got her better. But I knew I was complicit. And I knew that I had done something to hurt her. And so as a young chief resident at that time, a few years later, I thought we've got to change how long people stay on the ventilator. I designed a research project that Martin Tobin suggested we put the word spontaneous in the title for the New England Journal, and we helped develop this term, spontaneous breathing trials. A few years after that time, J.P. Kress did a study and published it in the New England Journal. I'll skip forward to that. Thank you, guys. Appreciate your help. I'm going to go past all this. That's Teresa, the young woman that I cared for that came back broken. She was, as you see, on 125 milligrams a day of benzos and morphine, and I called it a malignant normality later. I realized that I had developed habits as a clinician that would serve as a way of injuring other people in the name of what we thought was right. Willie Shoemaker had published beautiful papers on D.O.2 in critical care medicine. We thought you've got to drive that D.O.2 no matter what. Jean-Louis said he always gives enough fluid, but we were giving too much fluid. The people looked like, anasarca on steroids, and we were absolutely hurting people. So this was the paper that I designed in the New England Journal as a chief resident. All of these people here were trainees, except for my mentor, Ed Haponic, and I would have never thought to put the word spontaneous at the end of the title. That was Martin Tobin's idea. And then J.P. Kress did the same thing here with the sedation. Instead of stopping the ventilator every day, he stopped the sedation every day. And I described critical care as an arc. And this is the early portion of critical care when your illness is increasing. And then you level out in resuscitation. And then you have the back end of critical care. These two studies were about the back end of critical care. And what we realized was that we were hurting people. We did a great job of early resuscitation, but we didn't remove things on the back end quickly enough, and we ended up hurting them based on that. Oh, they switched computers, so now that slide thing doesn't work. One of my favorite authors, Ann Patchett, wrote this book called State of Wonder, and she says in there, in science, never be so focused on what you're looking for that you overlook the thing you actually find. What had happened was I was focusing on the elderly in the ICU. And what we learned was that the elderly patients were getting better from a respiratory perspective as fast as the young. But then they had more bounce backs to the ICU, and they had more death. So I found this unexpected thing. I thought we'd have to adjust the way we got people off of a ventilator based on 80, 90 years old. But that wasn't it. And I realized there's got to be a non-pulmonary reason for these people to be doing so poorly. And we started guessing. I thought liver, I thought kidney, I thought brain, maybe brain. So we developed tools to measure the brain and tools to measure sedation. And we used those tools in 2004 to show that delirium was a predictor of death. And Deborah Cook was the editor of JAMA at the time. And I had written this paper and called it an association. And Deborah said, it's not just an association. Your statistical tools here are predictor math. So she changed the word to predictor in the title, a stronger word. At the time in medicine, we had ads like this: diffuse anxiety for the continuous calm in the ICU. It's almost like we were sleepwalking into this by these ads. And the drug companies knew it. They knew we wanted a quiet, deeply sedated person in the ICU so that the sheets would be taut, everything would look perfect, and we'd leave them in the bed for as long as we felt was okay, and then we would wake them up. At the same time, by the way, before I get to this, in 2003, Deborah Cook published a paper in the New England Journal of Medicine with John Marshall and others, and she said that a person was 4 times more likely to have their life support removed if the person was judged by the doctor to be less than 10% likely to survive. And I thought to myself, wow, I've created that so many times as a clinician, where I've put people so deep in sedation that they look dead, Tom Petty used to talk about that. These patients look dead were it not for the monitors that tell me otherwise. And I started showing everybody Deborah Cook's paper. And I said, this sedation could be increasing the likelihood of me withdrawing the person's life support because they look like they're going to die, and I think they're going to die. As opposed to the same person with wide awake, looking at me in the eyes, I think, oh, this person's going to live. But that's all changed by me stopping the drugs. So Deborah never mentioned sedation in the paper, but to me it was a lot about sedation. And Margaret Heritage's work, beautifully published, the 1-year and 5-year outcomes in the New England Journal, likewise, is telling us all about the neck down complications past the ICU, which are clearly also related to oversedation. So those two women, Margaret Heritage and Deborah Cook, to me, opened my eyes to a need for change. A few years later in the New England Journal, we published this paper about cognitive impairment, and we showed that people were way down below these green lines in cognitive impairment. People started writing me letters like this. The husband of a 32-year-old survivor, doctor, she's not all there. The wit, the comprehension, the concentration. It's haphazard at best. To most, it's unrecognizable. The best way to describe it, mental disorganization. It's been 10 months. Is this it? So this man is married to this woman, and she's not herself anymore. And he knows it. And he's saying, wait a minute, what happened to my wife? Where's my wife? And I'm saying as a doctor, shit, I'm complicit. And I was walking around with chest pain because of this, because I knew that I was doing something wrong, but I didn't know what it was. And my wife said, something's wrong with you. I said, no, I'm fine. But she was right. And it took me a while. 20 and 30-year-olds having this problem. And what we found was that delirium was the #1 predictor of this acquired brain dysfunction. Others around the world started finding the same thing, LTCI at 1 year. Mild, 2.5, severe delirium, 3.5 times the predictor. So we started doing neuroimaging studies, and right now we're doing the second version of this brain study, Brain ICU. We've got $20 million from the NIH to do this, and we're enrolling patients, and we're collecting their brains. We have a biorepository where we have CSF, brains, brainstem, and we're going to look at the pathology and try and determine what kind of dementia this is. After this New England Journal paper, the NIH changed the term from AD research to ADRD research, Alzheimer's disease and related dementias. So underneath the umbrella of dementia, they stuck in things like critical care-related acquired dementia. It's ADRD. By the way, so after COVID, when we studied baricitinib, which I have no conflicts of interest with that drug, by the way, even though I was an author, no money, no stocks, no consultancy fees, I thought, well, all these long COVID patients are coming at me. We test them neuropsychologically. They're abnormal. Maybe they have an ADRD. So we went to the NIA. We proposed a randomized control trial, and we're now doing that. We just enrolled our 19th patient yesterday. Anyway, over time, what happened was that we took J.P. Kress's original paper and my original paper and then many others, 400 papers, and created this program called the A2F bundle. I do not think this is adequate, by the way. It's a framework. It's very hard to do to make people change the way they behave. We need to use AI. We need to use computer algorithms to do this. It cannot be all manual. Because by 2018, 2019, we did a global survey, and ICUs were, in 40 countries, were about 60 to 80% good at implementing these steps. We measured it, and in COVID, it went down to 10%. Nobody did any of this in COVID. People were behind the glass, they were getting heavily sedated, they were not getting woken up, they were not getting walked, it was thrown out. So when it's manual, it's too vulnerable to failure. And that's why, Jean-Louis, I love your talk, because you're saying, hey, we have tools. Let's be the pilots, but let's have a co-pilot. And right now, with the SCCM, we are rebuilding this program to be more automated. It's got to be. And by the way, there's a nurse that trained in Salt Lake named Kaylee Dayton, and she has said, Wes, we need just to call it an awake and walking ICU. Let's just call it something different, because if somebody can achieve an awake and walking ICU, given that we respect the team's trial, Hodgson's trial, and get the right balance, if somebody could say, I've never seen a walking person on a ventilator in my ICU, then you know you don't have an awake and walking ICU. Are your patients awake or are they all snowed? But before we get any further, let me just make sure that you aren't vulnerable to doctors saying that this is warm and fuzzy. Because I think when you go back to your ICU and you say, you know what, I want to wake our patients up every day, and I want to see if I can get them off the ventilator, SATs, SBTs, and I'm going to try and have the family at the bedside and get the physios involved earlier. Sounds like a great program, but the culture will defeat you quickly. And if a doctor says, well, that's all warm and fuzzy, I don't believe in that, it's not high science, here's what you say back. No, there are 400 papers, and if you just restrict the data in this area of the awake and walking ICU to the New England Journal, JAMA, and Lancet, there's over 40 of them. That's a pretty big deal. These are just New England Journal, JAMA, and Lancet. The B, the C, the D, the E, Margaret's, Harridge's beautiful papers there, and F, and all the way to PICS. I'll tell you two stories, I'll make fun of myself. First of all, when Gordon Moore, who was the founder of Intel, like Intel computer chips, got delirious in a hospital in Palo Alto, he was very frustrated that his family was disallowed. And he came to the SCCM hierarchy and said, look, I'm pissed. I was in the ICU. They wouldn't allow families. I'll give you money if you create a program that can allow my family and other people's families to be there when they're sick and delirious. And I had pitched to the Gordon and Betty Moore Foundation that we would do the A2E bundle. And Gordon Moore, like Seinfeld's famous No Soup for You episode, no money for you, sir, if there's no family. No soup for you. And so I said, well, let's add the F to the ABCDEs, and it'll be the A2F bundle. I did not even know that there were JAMA and New England Journal papers about this topic at the time. I was ignorant. But he was right, and we fixed it quickly. The other thing is, did you notice that I skipped the A? There are no New England Journal and JAMA and Lancet papers for the analgesia. That's the only one that doesn't have this highest end. And lots of other papers, 18, 25 papers on the bundle as a whole. Peter Drucker said, culture eats strategy for breakfast. And when Don Berwick, who was the most important person in medicine declared by Barack Obama when he was president, founded the IHI, he said, my motto for this largest quality improvement program in the United States, which is the IHI, the Institute for Healthcare Improvement, my motto is going to be, what can you do by Tuesday? In other words, on Monday in the unit, what can I say that by Tuesday, tomorrow, we will do this? And this is the way to change culture. It's not, oh, on paper, we will say this protocol, and this is now implemented. I declare it. The culture laughs at you. Culture says, no, I will not change. I will prevent you from changing. So instead, you say, you know what I'm going to do? I'm going to do small tests of change. And I'm going to gather on Monday, and I'm going to say, Miss Smith is here on the ventilator. What are we going to do tomorrow at Tuesday? And you say, we'll meet at her bed on Tuesday at 10. We'll use the computers. We'll have the prompts. In our hospital, we have red and yellow and green lights for each of the steps of the A2F bundle. We can tell if we haven't done it or not. And we can say, let's meet there at 10, and let's get her. Let's stop the sedation. Let's let her wake up. Let's see if she passes her SAT, SBT. Then let's get the family there to encourage her. Let's get her out of bed, and let's walk her. And I will kneel down and hold her hands and look her in the eyes to make myself small and to make her big. Because my pride is so big and so wrong that I have to kneel down and remind myself that she is the most important person and that I am just there to serve her. And all of this together creates a different mindset. And this is when you connect humanism to science. And the science is there, but the culture will defeat the science unless we get better at it. So just so that you're armed, what are the data? Well, the individual data, I just showed you the papers. But when you put it together, you've got, oh, there are 6,000 patients in this paper by Marianne Barnes Daly. And you can see, you're talking to your person back home. You can see that as you go up in compliance, you go up in survival. As you go up in compliance, you go up in freedom from brain dysfunction. And they can say, is that all? You say, no, that's not all. We have 15,000 people in the SCCM's ICU Liberation Program. And in that program, which was held at 80, 90 ICUs. You can see the map. We see that as you go up in compliance here, 0 to 30, 50, 60, you go over to a higher likelihood of getting out of the ICU, a higher likelihood of getting out of the hospital on the right, a less likelihood of death. This is what we wanted. You mean their data? Oh yes, their data. 21,000 people worth of data. And Michelle Gong from New York published another 4,000 person cohort showing that reduced cost. And then as you go up in compliance, you see, oh, we wake people up, we get them out of bed, we have the family there, and what happens? There's less coma, there's less delirium and physical restraints. Oh, but doctor, didn't they report that there was more pain? Yes, and we predicted that. Why is there more pain? Because the person is not delirious and they can tell you about their pain. Miss Smith, are you in pain? Listen, my brain works. Yes, I'm in pain. Would you please do something about it? So we had higher reports, which is great, because that's what you want to know, is how to reduce suffering. Kasha Katfus, who's working with critical care now beautifully as an associate editor, I believe, sent us this paper in Poland. You don't have to have complicated equipment. Get a grocery cart. This woman there with her husband is walking on the ventilator with a grocery cart. Now this fourth bullet, story of the Good Samaritan. There's this famous Good Samaritan study at Harvard. They said, okay, let's see what happens to people. Is it the will or the context? So they said, okay, all of you are going to give a lecture on the Good Samaritan at Harvard over there, and it's a 20-minute walk. So get going. People volunteered, these lecturers volunteered to be in the study, but they didn't know what it was about. And they had read the Good Samaritan. That's all their homework was. And on the way there, they were randomized, and half of the people were randomized to have a choking victim in their way on the way to the talk. So somebody's choking like this. And on the way there, the people who, those people who were randomized to that were told, oh my God, we took too long with you. You're late. You got to get over there in 15 minutes. It's a 20-minute walk. You better hurry. So they had this anxiety. Oh my God, there's all these people in this classroom. So, and they were going to teach about the Good Samaritan. You know the story. And they were like, the person choking, they go, oh God, I'm sorry. I wish I could help you, but I've got to get to this class. Skipped right over them. Why? Because context matters more than what we know. So we've got to create an environment in the ICU that allows us to be good. And part of that is what Jean-Louis taught us about with the AI. The computer can help us be good, but it will always come back to our own will and what we would choose to do. So I'm bringing the talk to a close now. These are my own lists. I have my ICU do's and don'ts. My humanism do's are put touch before technology. I talked about that earlier. Switch the preposition. Instead of me saying to somebody, here's what's the matter with you, I say, what matters to you? And when a person tells me what matters to them, I prioritize that. This is similar to the Three Wishes Project, started by Deborah Cook and colleagues. Teach and practice compassion, compatio, to suffer with. Take a knee. I showed you why I do that, because try and reduce my unwanted pride. And I always ask my patients or their families, tell me 4 things. You know, what's their favorite food, their favorite music, their hobbies. These are the things that, tell me their pets' names. And once I know that about a person, it's impossible for me to treat them as an inanimate object, even if they're in a coma. Don't overuse equanimity. Equanimity means even-keeledness. I did that for a while, and I really had chest pain because I was pulling myself too far back from the patients. And this whole idea of waking people up and looking them in the eyes got me over that. Don't separate loved ones. We did it in COVID. Wrong. I never want to live that way again. Don't be satisfied with benevolence. Benevolence is intended good. This whole program I've been talking to you about is about beneficence, actually doing good. Don't allow malignant normality. I talked about that at the beginning. Don't fear failure. So what? The person might fail an extubation. They might fail walking with the ICU. They might fail their SAT, SPT. Try it anyway. Be safe. The complication rates are very low. The team trial just published the complications of walking. They're about 5% more in the intervention group than in the control group in that study. Most of them are related to non-dangerous tachyarrhythmias. Very few had profound hypoxemia during those trials. I think the side effects were very tolerable. And the last I'm going to stop with is this picture. This is a picture of a patient of mine who was deaf. Imagine being deaf and intubated and unable to talk in the ICU. And it was just by accident that this nurse, Ellen, knew sign. She wasn't deaf herself, but her grandfather had taught her sign. And look at her. He's signing to her, and then she talks back to him. And they're having this whole conversation. Why was that able to happen? Because he was awake, off sedation, and not delirious. Okay? So this all comes back to mercy. Mercy, my working definition of mercy is, am I willing to dive into the chaos of another person's life and provide lifting and healing? Dr. Yassine Arabi wrote the introduction to a book that we're going to give 100 copies free down at the break. After this session is over, if you want a copy, we have 100 copies down there for free. Every penny from this book goes back to patients. And Yassine Arabi is going to read a short excerpt from this about mercy.
So thank you, Wes, for this great talk. This is really a strong reminder how to bring humanism to the bedside, how to become a human. So this is a very close topic to my heart, so is your book. Really, I love it. So I'm going to read in Arabic this section. لاحظت أنني في بعض الأحيان أبتعد عن أسرة المرضى وشعرت بقبضة محكمة تطبق على صدري. So, feeling human. وشعور بالألم. وفهمت أن ذلك الإحساس جاء من الشعور بالرحمة. رحمة, mercy. It's very important value. أصل هذه الكلمة من الميرسيكوديا وهي الرحمة باللاتينية حيث تشير الرحمة إلى معاناة القلب. So we are a doctor, we should suffer. We suffer with the patient. معاناة القلب أو التعاطف مع الآخرين. مشاركة المعاناة. المريض يعاني يشارك المعاناة معه. أعادتني كلمة مع with إلى التعاطف empathy بمعنى أن أشعر بشعور الآخرين. يمكن فهم التعاطف على أنه مشاركة الأحاسيس عملياً بمعنى القدرة على فهم الآخر والإحساس بمشاعره. رحمة, mercy, empathy.
You taught me a lot about being a better doctor. When we were together at your home, it was just such a beautiful experience for me to watch as you did this. And thank you today for honoring the culture here in Arabic, reading to us about mercy. And the story for those who don't know Arabic was about me saying that I had lost my way. And I lost my way as a doctor. I was so proud of myself for knowing the literature, reading 25 journals. And I thought, this is it. I'm on top of the mountain of science. I'm publishing in the right journals. And I got very depressed about 10 years ago. And it was because I had lost my joy. And this process of uncovering the connection between the science and the kneeling down and the eye contact is what woke me back up to what I love about medicine. And I'm fumbling in love with medicine now because of this. So I ask you to fall back in love with medicine if you've had too much of a focus on science. Use the data we showed you today, 25 to 30 New England Journal, 35 to 40 New England Journal, JAMA Lancet data. The science is there. Let's do a better job moving forward. And at the break, if you go down the stairs on the right, you can have the Arabic version that Dr. Arabi was just reading from for free. Thank you so much.
Thank you. The next speaker is Dr. Patrick Sinha. He's a physician scientist in intensive care and emergency medicine from the ICU of Washington University in St. Louis. His topic will be on the phenotypes in personalized medicine.
Good morning. First of all, Wes, thank you so much for that talk. It was useful. And, it's very prescient of the organizers to actually juxtapose the amazing talk by Jean-Louis and Wes together. And somebody who's deeply rooted into data science and artificial intelligence, it is becoming abundantly clear that one thing machines don't have is the motivation for humanity and our compassion and love, and Wes, you demonstrated that so beautifully. I will complain to the organizers, though, that programming me after those two talks is hugely unfair. And it's unclear how I'm going to follow up the Hollywood of Jean-Louis with the Taylor Swift of Wes with his mic. It's a difficult act to follow. So I am going to take a departure, and this is really where my talk is different from others, whereas Jean-Louis and Wes were so graceful in sharing work of other people. I'm mostly going to focus on the work that we have done in our group, and I'll explain to you the rationale as to why I'm doing that. I'm going to talk to you about precision medicine today, and something I feel very passionately about, how our field needs to move forward. Okay, these are my disclosures, none of which are relevant to the data that I'm about to show you. Okay, so to give you an overview of the talk, sorry, the laptop doesn't have my slides, but that's okay, I'll just work off the screen. So to give you an overview of the talk, what I'm going to talk to you about is what the current context of the problem is. And in my opinion, we are a specialty that grew largely out of providing supportive care for our patients. And so we converged on syndromes, i.e., what are the things that brings our patients to the ICU, and how do we manage those? And as a consequence, somewhere along this journey, I feel as though disease and biology has become obfuscated. So I'm going to talk to you about why that's the problem. Next, I'm going to talk to you about a solution, or the solution at least we think we're providing, and that's through phenotyping patients. Then I'm going to show you about the phenotypes that we have discovered and how we're going to implement those at the bedside. I'm then going to talk to you about the biology of these phenotypes, and then briefly touch upon what the future holds for the work of phenotyping. So let's turn our minds to what I consider to be the problem. Well, the first question is, what is ARDS? I have now been with my wife for 20 years, and when we first got together, she asked me, she said, what's your research about? And then I tried to explain to her what ARDS is. And sort of 20 years later, I still haven't been able to come up with a good answer. And this is the problem. It means many things to many people. And this is a lovely schema that Art Slutsky, who, I don't know if he's in the audience, but he helped draw up the advances we've made in the last 50 or so years with both at the bench and the bedside in terms of progress in understanding ARDS. Arguably, I would say, two of the most important, and potentially the third most important things have been left out. First is when we discovered the AECC definition. And this is when we tried to recruit many people, as the trend in medical science was, to try and have these large clinical trials to test interventions across populations. And that was considered the best, and it still is, the best we can do in terms of evidence gathering in medical sciences. This has now been followed up with the Berlin definition and more recently with the global definition. I haven't lent into that personally, so I'm going to stick with the Berlin for now. And so here's what the problem is. These are the symptoms that get you a diagnosis of ARDS. Arguably, these symptoms are met quite frequently, and there you have the chest X-ray. I think we all know that that can be highly capricious, and it depends from person to person. The interoperator sort of variability across diagnosing ARDS is quite large. But here's my biggest problem. At the bottom there is no link to etiology. And fundamentally, if you take biology off the table, and etiology matters, how you get to an injured lung is probably the most important part of how you get lung injury. In fact, if you go and read the paper of Ashbaugh and Petty, one of the things they described was, this syndrome is fine, but actually what you need to focus on is treating the underlying cause. 55 years later, we still have a definition that is unlinked to cause, and that's a fundamental problem. And here's what we know about the biology of ARDS. And I'm sure all of this is correct. In fact, some of these studies we have done and recapitulated, and you know, this is all true. But the problem is, we try to capture all this complex biology with these set of symptoms. And I have no doubt it captures those symptoms, but likely it captures a whole lot more. And to what degree this disruption happens at the bedside is hard to predict. So you may ask the question, why is this a problem? Well, here are some biological interventions. This is by no means a comprehensive list. It's a tip of the iceberg. All of these trials are negative. I guess another good question would be, well, what about sepsis? Arguably, things are even worse. This is what we understand about the complex nature of the molecular pathways that lead to sepsis response. We know that sepsis is not a single time point phenomena. It's highly dynamic, and yet, ostensibly, when it comes to diagnosing people with sepsis, this is what we've come up with clinically. We have reduced this complex interaction between pathogen and years of host exposure, epigenetics and genetics, and we try to capture these phenomena using really simplistic bedside markers. And this is a problem because in sepsis, we have had lots of negative clinical trials. And this is a problem because leading researchers in sepsis, this is Roger Bone and John Marshall, they've referred to sepsis and ARDS as graveyards for pharmacotherapies. And the reason why I have a big problem with these syndromic diagnoses is because when I talk to my patients at the bedside, it's really difficult to communicate anything meaningful when I use these labels. But more importantly now, as I'm moving towards precision medicine and I try and attract drug companies to think about sepsis trials, their enthusiasm is waned. And that is a long-term problem for patient care at the bedside. So I've told you about the problem. Here's what the solution is, or at least one of the solutions that we are approaching in the work that we're doing, and that's phenotyping. Broadly speaking, phenotyping, if you see at the top, we have a highly heterogeneous population. You try and find clinical or biological characteristics that separate people out. At the most simplistic level, you take ARDS, you could break it down into pneumonia, indirect versus direct injury, and then you can break patients down. However, and I think Jean-Louis touched upon this, is that perhaps given that our patients are becoming more complex, they're getting older, that the era for easy wins using univariate, i.e. one variable solutions, is probably well behind us. We need to start thinking about using multivariate solutions, i.e. lots of variables thrown in together to try and identify the complexity that we observe in our patient populations when we work in the ICU. And really, that's the phenotyping that I'm going to talk to you about, using complex biological multivariate measures. And there are two broad ideas about what phenotyping can do in terms of trying to do better trials and test therapies better. The first is prognostic enrichment. That speaks to how we can identify groups of patients that are at higher risk of the outcome that we intend to get or treat and make our patients better. The second, and that's the more exciting bit, at least scientifically, is predictive enrichment, that you identify a single feature or a trait which you can then target with a therapy and you can improve patient outcomes. Now, again, you can see that in cancer biology, we have made great strides. In fact, I was having this discussion at dinner last night that in the last 20 years or so, since I graduated from medical school, the biggest change I have seen is arguably through precision medicine and in cancer biology. And we have been working towards gradually of doing multivariate phenotyping in critical care. We have used lots of different, and this is the last bit where I'm going to show work from other people, and then I'm going to transition mostly to the work that we're doing, because I think arguably that's where most of the work has been matured in the critical care setting, and it gives a good framework of narrative to try and explain to you how this process might work. But other investigators have used bulk and single-cell RNA sequencing, emerging technologies, mostly based out of mass spectrometry, such as metabolomics and lipidomics, immunology, which is probably quite important when patients get to, when they get critically ill. There's obvious immune dysfunction there. And then protein, which is where I'm going to show you most of the work that we have done. All of this gets fed into algorithms and, again, leans into the work that we're talking about in terms of AI. And I think it's going to play an important role in trying to distinguish our patients who are temporally dynamic and they have a systems biology problem. So the work I'm about to show you is kind of 10 years of work that I'm going to try and do in the next 10 minutes. So it's going to be a very quick journey through this, but it's been pioneered by Dr. Carolyn Calfee, who's at UCSF. And at the outset, these are some of the things that we thought about when trying to identify phenotypes. First, in ARDS. We used a procedure called latent class analysis. It's a standard statistical model, which has become more democratic because of the higher availability of computational power. And so in the last sort of 10 to 15 years, it's seen a real explosion of using this type of modeling where you can take a bunch of variables. In some ways, that's when it's not unbiased because we select the variables that we put into the model. And then you ask the algorithm to do the work. You say, here's the data. You tell us what patterns you see in a population. We wanted to use a composite of clinical and biological marker. Arguably, in our syndromes, a biological diagnostic is what's been lacking. And that's been a barrier towards moving forward in terms of biological interventions. So one of the things we really wanted to do was add novel biological information and clinical data. In this case, we used protein biomarkers. Any phenotyping schema that you present to somebody, it has to be useful. It has to be robust, reproducible, and generalizable in order to translate it to clinical practice. And the clinical implementation side of things is really where the new frontier of how precision medicine is either going to be implemented at the bedside or maybe a barrier that is difficult or, I wouldn't say insurmountable, but with considerable amounts of challenges. And that's mostly the lab that I run. We are focused on clinical discovery and clinical implementation of phenotypes. So I'm going to describe to you two phenotypes based on a composite of protein biomarkers and clinical data. On the x-axis here are all the continuous variables that we use in this model. On the y-axis is their mean standardized values. So how does it differ in each phenotype? The red line here is called the hyperinflammatory phenotype, and it is defined by high IL-8, IL-6, soluble TNFR1. These are markers of inflammation and endothelial dysfunction, as opposed to they have lower values of bicarbonate, so more acidosis, lower platelets, more shock, so increased organ failure, more inflammation, more endothelial dysfunction, and this all seems quite intuitive, something we can all, I think, get behind. The hypoinflammatory phenotype, and this is where, if I could turn back time, I would have called it something else, is a slight misnomer. To give you an idea, inflammatory markers in the hypoinflammatory phenotype are in an order of magnitude higher than we observed in COVID-19. So these are not hypoinflammatory in any way. They are just not hyperinflammatory, where these inflammatory markers and endothelial dysfunction markers are by several order of magnitudes higher. About 30% across multiple cohorts are the hyperinflammatory phenotype. And this is a lot of data here, but I'm just trying to show you the reproducibility and generalizability of our work that we have done. These are multiple cohorts of ARDS. They include observational cohorts, randomized controlled trials, and at the bottom here, these are pediatric cohorts of ARDS, all of which, using unbiased techniques, modeling, and doing statistical testing, have shown that two phenotypes exist in this population, and consistently, mortality is higher in the hyperinflammatory compared to the hypo, slightly different in the pediatric population because overall mortality is lower. Nevertheless, I hope I've shown you consistency and generalizability and perhaps some utility in terms of prognosis. So the reason why I think some of this has taken traction is because then when we looked at these trials and did secondary analyses, we found that treatment response, albeit in secondary analyses of trials, was different in the two phenotypes. It was different when we looked at alveoli trial and PEEP. It was different when we looked at fluid management strategies in ARDS. And it was also different in HARP2, where intuitively simvastatin therapy showed a benefit, a survival benefit in the hyperinflammatory compared to the in the hyperinflammatory phenotype compared to placebo, but not in the hypoinflammatory. Important to establish that when we used other metrics of severity like PF ratio, Apache score, we did not find the same differential response to therapy, suggesting that there's some additional information that we're getting out of these phenotypes. So what with this inflammation and endothelial dysfunction being the main drivers, we asked the question, are these phenotypes seen in sepsis? And yes, they are. When we excluded patients with ARDS in multiple observational cohorts, we found the same two phenotypes. When we built models that predict the ARDS phenotypes and pointed them to sepsis phenotypes, again, we found that these models performed really well. The AUCs here that you see are extraordinarily good, considering we trained the model in a completely different syndrome and pointed it out in a different syndrome. And we have now repeated this in over 4,000 patients that we have published, and where we presented abstracts in, these numbers are approaching tens of thousands of patients now. And it's important that this work isn't just being recapitulated by us. There are several other investigators at different centers who have all shown that these phenotypes exist in their population, and this number is ever growing in the literature. So again, I've shown you that there's generalizability that's expanded, that is beyond syndromes and perhaps agnostic to syndromes. The data that I've failed to show you that in one sepsis cohort where prevalence of ARDS was 3%, we again found the same phenotypes, suggesting that maybe ARDS might actually be a manifestation of this phenotype rather than the other way around. So the problem is that I've shown you a multivariate solution, 30 or 40 variables using complex modeling. How do you take that, and how can I bring these phenotypes to your bedside in the ICU and or in the emergency department? So we took two approaches. One was to minimize the number of protein biomarkers, and that's a problem because there are no point-of-care readily available multiplexed multivariate measurement systems. And the second approach was to use machine learning and take the biomarkers off the table. So I'm going to show you some data rapidly. These are sort of a 3-variable model using IL-8, bicarbonate, and protein C, or you can use IL-6, soluble TNFR receptor 1, and the AUCs are comparable. These are really good predictive models. This is different permutations of the variables that you can potentially use. The limitation here, of course, is that you do need protein biomarkers. However, in the HARP2 study, using these parsimonious small 3-variable models, not 30-variable models, we were again able to find the same treatment effects. This is a study with Danny McCauley and Tamas Zakameni, where we showed feasibility of using a point-of-care multiplex assay. This is a novel assay that was developed specifically for identifying the phenotypes in 39 patients. It's a small study where we used IL-6, soluble TNFR1, and bicarbonate, and this device, which you can see in the bottom left-hand corner, where there's some very new and exciting data that's about to come our way. I can't tell you too much, but we've expanded these studies into 550 patients, that we showed that real-time phenotyping using a device that is currently available is feasible in large populations in the ICU, and the prospective validation is coming your way shortly. We asked also the question, are these phenotypes stable over time? This is a study that we recently, actually I should change the bottom, it's recently been accepted, published in the Blue Journal, and it's with Rambat Amstel and Louis Bos from Amsterdam, where we looked at the transition of these phenotypes and found that actually these phenotypes are highly dynamic. By 48 hours, only half of the patients who were in the hyperinflammatory phenotype are hyperinflammatory at 2 days, and by day 4, that number goes down to about 10%. And not only that, if you switch from hyper to hypo, your outcomes improve, but if you stay hyper, your outcomes are worse. If you go from hypo to hyper, your outcomes are the very worst out of all of these patients. So how you change has important implications. Also, where you get diagnosed with a hyperinflammatory phenotype is also important. This is the Clovis trial, which was a recently completed septic shock trial. In that, again, we found the two phenotypes. Here, by day 3, only 10% of the patients who were hyper originally were hyper. The transition was much quicker. And importantly, if you switched from hyper to hypo in the Clovis trial, your outcome was as good as if you were being hypo. So where you're sort of labeled as hyperinflammatory is also important, and how long you're in that state is important, suggesting that getting people out of this state is probably quite useful. So I'm going to show you very quickly, as I'm running out of time, about a clinical model we built just using a machine learning model and vital signs and labs. That's the only thing that's included in this model. And this work was done with Matt Chopek and Carolyn Calfee. And again, the models had good AUCs. And when we pointed this model into alveoli, we found that not only did it find two groups, hypo and hyper, with different outcomes, that the hyperinflammatory phenotype had a benefit with high PEEP and harm in the hypoinflammatory phenotype with low PEEP. And this was the same as the LCA models. It really recapitulated it. And remember, we trained this to predict the phenotypes and not outcomes. Using this model, we then looked at the Prowess shock data. You may all remember Prowess shock. This was a trial that tested activated protein C in patients with septic shock. And for those of us who are of a certain vintage who've used this, you'd give it to somebody and go, wow, it works. And then you'd give it to somebody and go, I think I might have done something bad here. And hey, you know what probably happened is that, okay, so the Prowess shock, it showed no benefit with placebo and activated protein C. Multiple subgroup analyses, again, no difference in outcome. However, when we check the treatment response according to phenotype, on the x-axis is how hyperinflammatory you are. So if you're really hyperinflammatory at a probability of 1, you can see with the green line, activated protein C confers a treatment benefit. However, if you're really hypo, where actually your baseline outcome, your mortality is only about 15%, giving activated protein C caused harm. And it makes perfect sense if you understand how the drug works, what its putative benefits are, and what its risk to benefit profile is. So again, suggesting that we may have discarded many therapies as a consequence of our syndromic approach. Another trial, I'm going to wrap this up very quickly, was the polymyxin B trial in patients with high endotoxin levels, really sick patients. We thought everybody in this trial was going to be hyperinflammatory. Turns out only 50% of the patients were. I want to just show you what is the favorite image that's come out of my lab. On the x-axis here is the probability of being hyperinflammatory phenotype using a machine learning model that only uses clinical data. So no biomarkers, only clinical data. And I will posit to you that there are not many biological responses that have a bimodal distribution. And this suggests to me that actually what we've captured is not because I'm a great data scientist, I'm probably below average because I started learning only in my late 30s, that actually we've discovered something that's quite real and something that's quite biological, because only when you point things at biologically distinct groups do you start seeing bimodal distributions using what is essentially a continuous variable at the bottom. Again, here too, we found that the hyperinflammatory phenotype responds to polymyxin therapy, but the hypoinflammatory phenotype is harmed by it. And to briefly touch upon the biology, we think this is converging onto a bacteremic response in patients. The hyperinflammatory phenotype has about 30% bacteremia, mostly dominated by gram-negative bacteremia. This is true in 2 trials. And in this work with Lucille Nathan, who led this project, we found using metagenomic sequencing that overall DNA bacterial load was higher in the hyperinflammatory phenotype and was mostly driven by E. coli. So we've come full circle, we've discovered something in ARDS, and actually we found a signature of specific host response, what we think is to Enterobacter acei. And here's another cool study that I'm doing with Rishi Chandaraj and Bob Dixon, both from the University of Michigan. Take your eyes right to the end, where these are bacteremic patients with Enterobacter acei. You remember I showed you that bimodal distribution? In patients who are Enterobacter acei blood culture positive, your probability distribution is exactly like what I showed you in the polymyxin B trial. That if you are gram-negative, the lowest probability you have is being 0.5. So you're either hypo or hyper, and that's not true if you're Staph aureus, getting there with other gram-negative bacteremia. So an analysis from this downstream has shown that gram-negative bacteremia, specifically Enterobacter acei, is the biggest predictor of the hyperinflammatory phenotype. I'm going to skip through these. So the future, I think we're moving towards phenotype-specific trials. First of all, the FIND study, we hope, where the data will be presented, might show us that phenotyping is possible in real time. The Panther Consortium is basing the technology from the FIND study and is going to start testing therapies based on these phenotypes. So unlike 2050, I hope that these phenotypes will come to the bedside much closer than that. And in the interim, and one of the reasons why I built this machine learning model is because I want to expand this phenotype information beyond countries where these expensive machines can be afforded. And we built this machine learning model, and we have a website which we're going to launch soon, where you can go in and enter information about your patient's vital signs and labs, and it will tell you whether or not your patient is hyperinflammatory. And then the other question and soul searching that we need to do is, what therapies do we need to test in the hyperinflammatory phenotype? And it goes back to, what therapies did we discard that we thought would help our septic patients, but we just didn't know how to translate the knowledge we'd gathered into the bedside. So to summarize a decade's work, measuring biology now in 15,000 patients. So we have phenotyped 15,000 patients with biology. I just want to point out, Ashbauer and colleagues had 12 patients with ARDS. 15,000 patients, we've described the hypo and hyperinflammatory phenotype. About 30% is hyperinflammatory. Higher levels of protein biomarker, endothelial dysfunction, inflammation, higher organ failure, associated, we think, with Enterobacteriaceae, but not completely, but it explains a lot of the variants. And it seems to respond differently to a multitude of therapies, albeit in secondary analysis of trials. A bunch of people to thank. Really, a lot of the work I do is scavenging on other people's greatness. And so I'm really grateful to all my collaborators and people who work in my lab who really generate all the great stuff. I just talk about it. And with that, I thank you very much for your attention.
Thank you so much, Professor Sinian. We have our last presenter for the morning, Professor John Fraser, coming from as a director of the medical ICU at St. Andrew's Hospital in Brisbane, and a researcher. He's going to give us a little perspective of digital transformation, right? So, thank you.
Assalamu alaikum. Shukran Mafi for coming up so early in the morning. And hopefully we're going to see the slides shortly. So, wonderful array of presentations this morning. We've gone from the humanity to the phenotyping, but I would suggest to you that we can combine the two, inshallah, which we may do with some slides. There we go. We've got some slides as well, so that's good to see. So, I would say that humanity and the science can be done simultaneously. They're not mutually contradictory, and this is part of what we're trying to do in this project. It was great hearing the last talk. I actually do a whole pile of phenotyping in ARDS and sheep with Danny McCauley. Some people would say Danny is the dumb animal, but I think that'd be a bit unfair. But on the other side of it, my dad ended up in intensive care and got really bad delirium. So we move away from latent class analysis and ventilated sheep, where we've done RCTs and based on phenotype into this, because I think what's important to us is what happens to the patient. And survival is not enough. So the patient has to thrive, not just survive. Now, what have we got to move this forward? There we go. Survival has to be worthwhile. I've got no slides here, so I'll just move to the side. We've heard a lot about this morning about delirium and the problems associated with it. And there are definite advances forward, but we don't have a magic bullet, nor do we have it in sepsis, and hopefully endotypes will teach us a fair bit about it. But delirium is a massive, massive problem. It's a massive problem for my dad. It's a massive problem for our patient population. It's a massive problem for their survival, their morbidity, and it's a massive problem for the cost of the hospital because it's very, very common. The problems that happen after intensive care, it doesn't stop. When I was a trainee, it was just one of those things that get better from it once they come out of intensive care. But it's very, very clear that if you get delirium in intensive care, your morbidity increases, your mortality increases, your risk of marital breakdown goes up, your chance of going back to work goes down. So you cost society a huge amount of money, but you never can go back to earning a lot of them because of this. And the whole family dynamic, it's not just the patient, it's the whole family dynamics changed, and we've got to be able to do better.
we've always looked at the delirium, and I tended to think it was the people that have been there for 2 or 3 weeks on a ventilator and dialysis and ECMO, but it's not true, and this is some of the work we've done very recently on PIC syndrome, and really it just shows that you can get post-intensive care syndrome, been in the intensive care for 24 or 48 hours. The orange is those that have got an impairment, and the brown are no impairment, but even within 24 and 48 hours, and you don't actually need to be ventilated. So the intensive care is an important point, but as one of my colleagues, an intensive care specialist who was in intensive care for himself says, he says intensive care is a necessary evil. A necessary evil, and that's the place we work, ladies and gentlemen. So we have to do something better for the patients there, because it's a problem, and there's different trajectories, and we don't understand why. So I'm not going to go through this. We've had great speakers already this morning talk about the identifiable causes of delirium. These are the things that we can't change. You can't change the age, the dementia, the sexual status, or the ventilate, or the other things. But there's many things that we can change in the intensive care, and unfortunately we haven't bothered trying to an extent. The noise and the light in the intensive care is a phenomenal problem. We've all had those busy shifts, and we get out and we go for a coffee, or we go home and you think, thank goodness for that. That noise was terrible. The lighting is such an important factor, and we're going to talk about some of the science. And the science that's been done and what the light does to your hypothalamus and your circadian rhythm. And your circadian rhythm controls everything. I just flew in from Australia yesterday, and it was 18 hours, and I'm still jet lagged. But I'm not there for a month, and I don't do it every day, but that's what our patients do. And we haven't really looked adequately at what's happening with the brain and the environmental features, because the environment is so important. Look at this beautiful hall and the beautiful lighting and the soft noise. It's been made so that we appreciate it and we can sit and we can learn. But we haven't done this because it's about us. We've talked about the way that intensive cares have been developed or built on the ABC model: the architect, the builder, and the CEO. And the patient hasn't been involved, but the patient is the consumer. We get to go home at night sometimes. The patient is there, but we haven't said that. Can you imagine going to a restaurant where no one had asked a customer what they felt about the environment? It wouldn't happen. And patients are now becoming active participants in healthcare rather than passive recipients. So these are some of the things we need to do. The circadian rhythm controls not just your sleep, but your physiology. The lack of sleep is a massive problem. Being unable to speak and unable to communicate, and we've done a lot of work with Annalisa Sutt on this. The use of our technology, we've got fantastic, latent class analysis and things, but the way that we use modern day technology, visiting, we talked about visiting in COVID, using WhatsApp or Zoom, you can do this easily, but we haven't adapted this because the hospitals say, oh, that's different, we can't do this. So we don't use technology well for our patients, and patients feel like they're clones. They're not seen as individuals. We're talking about personalizing the latent class analysis, but we're not seeing Mrs. Smith in bed 6 is different for Mr. Al-Shawadi in bed 10. They are different, and out in the community, they're treated as different, but we treat them as clones, and that is not the way we should personalize healthcare. So I'm just going to show this little video. If you can press play, please. Hi. Audiovisual, can you press play on this one? And turn up the volume, please. Audiovisual, can you turn up the volume, please? So this is the fear, and we've actually taken a lot of this from patient data. We started with our patients asking them what it was like to be in intensive care. No. Chaps, can you get volume? Okay, thank you, you're onto it. We started this not with the architect, the builder, or the CEO. We started talking to past patients. We did a lot of work in delirium. We made a language-free app screening for it. We saw the incidents. So if we just go back to the start on that, please, if you've got the volume now working. Yeah. They promised me it was working. And talking to the patients and the relatives about the fear they face. So this looks Hollywood, it's not. These are based on patient and relative complaints and concerns. And when you talk to the relatives and patients, and that's where we started, Do you want to try it again and see if you can get volume? When you talk to the relatives and patients, they say intensive care is amazing, you saved our life, you're wonderful, and then you actually get down to it and you talk about the delirium and you talk about the fear. So we had a number of different patients, some of whom were our poster boys and girls. One young lady had a heart double lung transplant. She won Special Olympics or Transplant Olympics. She's a model, she's on television. And we always say, look how wonderful we've been at our hospital. And we brought her in to talk to us as we started to talk about personalising the intensive care. And she said, transplant was fine, sternotomy was fine, drains were fine, but every night when I went to sleep, I would close my eyes.
My head would go and feel myself dissolve through the pillow, dissolve through the bed, fall to the floor, and dissolve through the floor to the next ward. So the only way I could stop it was open my eyes. And she was there for a month, and she was petrified of falling asleep every night. 4 years later, she still cries every time she was past the hospital. The risk of post-traumatic stress disorder, post-delirium, is higher than that of a Vietnam veteran. And quite rightly, there's a lot of money spent on veterans, but we don't do this for patients that suffer delirium. All right, I'm probably going to give up on that. That's a shame. So it's important for our patients, but it's also important for our healthcare workers. We were hearing a little bit before about how horrible an environment COVID was at the time. But our healthcare workers, our nursing staff, respectfully are more important than the doctors. And if you look at the problems of post-traumatic stress in healthcare workers, this is a huge problem. And it says that between 1 in 3 nursing staff are looking to retire or resign in the next 3 years. So if we don't have nursing staff, we don't have intensive care. If you look at how medicine has progressed, it's phenomenal. Most of it done by Scottish people, antiseptics, antibiotics and anaesthetics, and I'm not conflicted. But if we look at how medicine has changed over the last couple of 100 years, it's changed phenomenally in our treatments. But if you look at how the other things have changed, this was a telephone also invented by a Scotsman, and this is what a telephone looks like now. And it's changed dramatically. But if you look at the environment where you treat these more complex patients, that's what a Nightingale ward looked like years ago, and this is what the ward looks like today. And in fact, it's just got worse. It's just got worse. The bed is facing away from the window, so the nurse or the doctor gets access to the light. And what all this happens is it's got noisier and noisier. Florence Nightingale even said, noise is one of the cruelest things we can do to our patients. But noise is a phenomenal component of intensive care medicine. So we looked at the problem and we said, how do we address it? We looked at the noise levels, and in our unit it's a 27-bed major cardiothoracic hospital. During the daytime, the volume of the noise is the same as trying to sleep in a 6-lane freeway. 6-lane freeway, you think, that's terrible. But surely at night time it's better, and it is better at night time. The normal noise level is lower. But 83 times per night over a month survey time, 83 times there's a delta, a change in the noise big enough to be the same as a lawnmower starting within 1 metre of your head. So, surely class analysis of phenotype is really, really important. But it doesn't matter what your phenotype is if someone starts a lawnmower 1 metre from your head and you don't get any decent sleep. And if you look at where the noise comes from, it's an incredibly bizarre thing. 95% of all the noise in intensive care comes within 1 metre of the patient's head. So the monitor sits here, the ventilator sits here, the dialysis, the echo sits here. All that noise is concentrated within 1 metre. But the doctor or the nurse is down at the back. They're not going to change the type of volume, they're not going to change up your vasopressors. Why does the noise come from there? And it's because when we started intensive care, we grew it out of operating theatre when the patient was unconscious. And unconscious is probably not great, but it's not that bad. But now we're talking about our patients mobilising, getting the families in, which is of course important. But we have to look at this, because to not be able to sleep is torture. And it's 2 metres from the nurse. So the person that's giving the care is far away by the time they get down there. It's changed. This is one of our normal bed spaces, and we looked at the different sources of noise relative to the patient. And this is where the noise is coming all around here. We looked at our data just from the monitor. So again, 21-bed ICU, we looked at 31 days. How many monitors? So forget the ventilators, the infusion pumps, the echo, the dialysis. Just from the monitors, we had 600,000 alarms. 600,000 You say, well, alarms are good, we need alarms, so alarms are good, more alarms are better. But it's not the case. 95% of the alarms didn't need any action. But because we like alarms, we did it for ourselves, not for the patients. Light, a massive problem, we'll go through this a little bit quickly, a massive problem that cues your sleep, your weakness, your cortisol, your stress response, your insulin, your everything. But we destroy our circadian lighting in intensive care because there's been almost no work done on the lighting in intensive care. And you imagine again, look at how useful this lighting is, but we haven't done this in our intensive care environment. So what happens with the sleep is you get between 3 and 5 minutes spells, the amount of REM sleep is almost negligible. And so everything is disrupted. And again, the number of nursing care activities in our unit was 42.6 per night shift. Do we really need 42.6 times to be moved around or taken observations, or should we really just let the patient sleep and be less unwell? Okay, I'm feeling lucky. Chaps, are we getting sound? Audio visual? Give that a blast. No, that's so, you watch the video, we've got some text here. We've all seen this. This is funny, it's funny with the audio. But the number of times our patients get disrupted through the night for what we consider important things. Can we just let it go? Not to worry. It's okay, you can reach it. So the number of times our patients were bothered by the president, the nurse, junior doctor, the med student, the senior fellow, and by the time the night shift is finished, they're so exhausted they hardly use. And then they end up going for a scan with it. They just get changed and changed and changed. So the way that we've developed our care might work for us, but it's not about us, it's about our patients. We'll just press on, guys. Sorry, audio visual. Hiya, up here. Can you just let it go on, thanks? Chaps, hiya. Just let me press it forward. Can I just take control of the talk again? No? Okay. So, I can do a dance and a song. So, from the lighting point of view, we have now looked at the lighting. And lighting is absolutely non-circadian. We've looked at the wavelength of the lights. And if you look at the electric light,
I think it's asleep. What is that? Sir, you need to keep your arms straight. This the whole night? Or it'll keep beeping. You won't get your antibiotics.
We have a rapid response in room 302.
What is that? It's time for your midnight vitals. Why do I need midnight vitals? Doctor's orders. This is giving me a headache. Would you like me to ask the doctor for a Tylenol? Do I know? Got your Tylenol here? What? Just let me sleep. Okay. All right, sir, it's time to draw your blood. It's 3 a.m. Uh-huh. Hey, sir, I'm drawing the medical student. How was your night? I'm fine. Hey there, sir, I'm Dr. Smith, the intern. Are you doing okay? Yeah. I'm gonna go get my senior. Sir, I'm Dr. Jones. Can you follow my finger? Look at the light. What day is it? Tuesday or... He doesn't know what day it is. Yes, it is. Was he like this last night? He was more awake earlier in my shift. I'm ordering a stat CT head. No, just let me sleep. We did good work in there, team.
It might be a joke, but we've all done it. So what can we do about this? We can do things with various different drugs and mutations, phenotypes. But the humanity is, let's make the environment better for them. Because the bed space, the people that are there are most of the patients and the relatives. So we started with co-design with patients and relatives. And we brought in the hospital designers. And the hospital designers that designed most of the hospitals in Australia said, this is the first time we've ever met a patient. This is the first time we've ever met a patient. We've met the CEO, we've met the budget holder, we've met the doctor that sits in the office. We've not met a nurse. We've not met someone who cleans the sluice, so we've never met a patient or a relative. So we started with this. We started looking at circadian lighting, making virtual windows. I flew across the AC-80 and Shukralaki to Upper Raman. I got a business class, first class seat, and they've got the virtual windows. So we created virtual windows because almost all the windows in the intensive care are behind the patient. So the nurse or the doctor gets a window and the patient gets nothing. and this can also change your circadian lighting as well, which has been lovely. Virtual visiting we started way before COVID, but how sad it is that the patient can't see. We've got a large rural population, and the farmers and whoever just want to see their farmer, sometimes their dog, sometimes their wife, more commonly their dog, and to be able to do virtual visiting with them is a phenomenal, and it's incredibly cheap. We started looking at the design. How do we make a cocoon of care? We started different types of designs, because ICU, as we heard before, and both phenotypes and everything else, is a dynamic situation, so that your period of care changes when you're maybe day 1, when you're sedated, ventilated. In day 2, we start to get immobilized. In day 3, we start to try and move around. So these are all actually doable designs. So we, and again, just to speed up, rather than just do research, we wanted to do living research. These are the 2 worst days in our intensive care. We were given them and said, we can't use these. We used the top one for simulation, the bottom one just for intermittent chemo. All the noise, as we said, comes from back. This is the lighting the patients get. And what we did, so we built this over a couple of years. We moved from this, on patient-based, relative-based design, to these intensive care beds. So these intensive care beds are the same size. We built in virtual windows on the wall. We built skylights, so this is circadian lighting. We've actually worked with lighting engineers to go outside in Queensland and look at what the normal light intensity is. Morning, afternoon, lunchtime, evening, dusk, and we've just got almost the same wavelength coming through these lights. The walls were made, we built with Boeing, so these are noise-cancelling walls. You don't want noise-cancelling speakers, but these walls absorb about 47% of the vibrance. The floors do the same. They're washable, they absorb noise, but not bacteria, and so many other different features. So what we've got here is the monitor's still at the back, we've got a second monitor, so we throw the noise from the monitor to the feet of the bed, so it's away from the patient and close to the nurse. And we can do a lot of it from the outside at night shift. So what we're trying to do is reduce delirium and improve outcomes, improve sleep, improve patient and staff experience. And these are some of the ways that we can do it with sound masking, wireless equipment, digital use of light, better visitors, electronic visitors, asking the patient and the relative what they want. It doesn't be that hard. Just moving the alarms to the feet of the bed drops the noise the patient hears by 50%, which is a huge, huge result, and cheap as chips, really. This is a fascinating slide, because I assume this has been done before. So this is, we looked at the wavelengths in the intensive care. We put a monitor on the pillow beside the patient, and this is the normal, this is the wavelength distribution for the lights we were seeing. And we went outside in the same day, we measured the light that our patients would see day in, day out, morning, afternoon, evening. This is just the normal distribution curve. And you say, well, what about if we've got a window? This is one of our patient bed spaces with a window. And essentially the electric lighting drowns out any of the benefit of the window because it's behind you. So the patient's eyes and the patient's pituitary really just sees electric light and doesn't see any benefit. So working with the engineers, we're building our own lighting system. We don't have it right just now, the peak down here is the blue light, but we're still optimising the wavelength distribution of the electric lights, and now looking at trialling this for circadian lighting. We'll just press play this one, feeling lucky here. Press play, chap. So this is how we actually did it. We built the street over that was long. As well. We did do a healthcare cost analysis, and because if we reckon we drop the delirium just by 10%, these bed spaces will pay for themselves within 2 years. which is phenomenal. So it looks expensive. You should look in the UK and they say forget it. But if we can get the patient out of intensive care quicker and reduce the morbidity, it's a phenomenal thing. So now what we're doing is saying, oops, big one. Can we go back, please? So now what we're saying is it looks good. It looks good, but does it actually make a difference? So what we're doing is a randomised controlled study looking at a whole pile of the markers that you heard in the previous talk about latent class analysis, looking and seeing, randomising to a normal bed space versus the ICU, the future bed space, and see do they have better sleep, do they have less delirium, do they have different inflammatory markers, their EEG recording is different. And I'll finish by saying, we talk about personalising healthcare, finish by saying we looked at how many times, how many manuscripts have been done, we had great data, phenotyping, etc., thousands of patients. In the full time of intensive care, less than 100 patients have ever been asked for input into the design of their intensive care. 70 years, millions of patients, less than 70 patients. So I would say to you, the ICU, the environment we have is a necessary evil. We can do better. We shouldn't look at it from the architect, the builder, the CEO concept. We should look at it as the patient and think about it, what if it was your dad. So these are some of the things that we're looking at. Thank you for getting that back up. These are some of the things that physical and a whole pile of blood data as well. And less than 100 patients and their families have ever been interviewed as part of the ICU design, which is an indictment of ourselves. So with that, thank you to the audiovisual guys for getting it working, and I'll stop the job. Thank you.
Thank you so much, Professor Fraser. Unfortunately, we're running out of time and we have a break right now, but in 5 more minutes we'll start a new session. So we'll leave the questions for anyone directly asking the speakers if you want during the break. Thank you so much for the attendance. Bye.